Sure. Thanks, Jason, and thanks to all the organizers for putting this together. So I'm Jacob Vogler. I work at Mathematica. I think on the conference schedule it says University of Illinois, but that's where I graduated last May. So today I'm happy to present my job market paper, Rural Hospital Closures and Local Economic Decline. So to start, I kind of want to talk about what a broad motivation I had for this project, which was thinking about why rural economies are struggling, right? So it's probably not surprising to anyone here that in the last several decades, rural areas have experienced declining population, declining economic activity. And so I was, thinking about why this is going on. I'm from a rural area. It seems like whenever I go back, things kind of tend to get worse and worse. So when I looked at the research, most of the effort has been putting into thinking about what I call pull factors to urban areas. So the idea here is that people, mainly younger people, are leaving urban areas to take advantage of things like higher wages, more desirable amenities in urban areas. And this, of course, is going on, but sort of the flip side of the coin, and where there's comparably less work, is thinking about the idea, well, maybe there are shocks that are occurring within rural communities, both in terms of the local labor market and also shocks to amenities that people care about that are pushing people out who otherwise would choose to stay. And so this paper kind of touches this third point. And to do so, I examined in a very broad sense what happens to rural areas when a local hospital closes. So there's a couple of reasons why I think studying rural hospitals, particularly closures, is quite interesting. So the first is the trend in rural hospital closures has been steadily increasing over time. So you can see from these two figures, although they're not updated to 2020, the number of total hospital closures in rural counties, and I'll talk a little bit more about how I define rural counties in a little bit, has been steadily increasing, right? Especially in the years after the Great Recession. And this has been true for both for-profit and not-for-profit hospitals. And of course, this trend has garnered the attention of not just researchers like myself, but also residents who live in these communities, as well as folks in the media and public policymakers thinking about, not just the causes of these hospital closures, but what are the consequences. So here's a, couple articles that I read while I was doing research for this project, and a lot of the attention, of course, has been focused on health outcomes, things like mortality, things like access to healthcare, and where there's been, I think, less thought has been thinking about the economic ramifications, right? And of course, that's what my paper focuses on. So that's the first motivation, right? There's this increasing trend. There's no real reason to think that it's going to stop, especially in the wake of COVID-19. And yet we still don't know a lot about what are the economic ramifications of these closures. The second motivation is that studying hospitals sort of represents or presents a unique opportunity when thinking about local labor market shocks. So if you were to compare a local hospital in a rural area to, say, a manufacturing plant, both produce a lot of jobs, which facilitates consumption of local goods and services. And so if either of those close, you certainly would think that there's going to be effects on the local labor market through the local labor demand channel. However, hospitals, unlike manufacturing plants, serve as this important quality of life component, right? They have this sort of inherent amenity component because everyone uses healthcare throughout their life, particularly as you get older, and it's certainly true that rural areas in the U.S. are aging, and so when a hospital closes, you would think that not only is there going to be effects through the demand channel, but also through the supply channel as well, as presumably it's going to have some impact on location preferences, both for firms and residents who are currently in the rural community, but also firms and residents who are thinking about maybe moving to an area that doesn't have a hospital. So so this is a little bit different than most other firms, particularly manufacturing in rural areas. So this paper is kind of separated into two parts. In the first part, I'm going to exploit county-level variation in all hospital closures for about a 15-year period, going back through 2003 and ending in 2017. And using this data, I'm going to be estimating a difference in differences design, where at least at baseline, I'm going to be comparing rural counties that have a hospital and where one closes to rural counties that have a hospital but where one doesn't close. And I'll talk a little bit more about the empirical strategy and sensitivity analysis from this part of the paper. And then using these reduced form estimates, I'm going to develop a spatial equilibrium model that's not only going to ground my estimates in theory, thinking about are the magnitudes or the directions in line with what a theoretical model would predict, but I think equally as important, it allows me to characterize welfare impacts for different residents in the economy. And here I mainly focus on differences between older residents in the rural in a rural economy or in a rural community that loses a hospital, and then younger people who are in the labor market. The reason I do this is that older individuals have higher moving costs, they have higher mobility frictions. The literature seems pretty clear on this, but they also utilize hospitals much more often than younger folks. And so, you would think that when a hospital closes, the welfare effects are going to be different among these two groups. So a quick preview of the results. What I find with my baseline analysis is that these closures adversely impact essentially all the economic outcomes that I look at, including employment, income, labor force participation, decreases in housing and rental prices. The two big takeaways here is that I don't find evidence of differences in trends between treatment and control, and I'll show you figures that provide evidence of this. And secondly, this doesn't appear to be a non-transitory shock. Okay, so this doesn't appear to be, a phenomenon where a hospital closes, the economy takes a dip, but then reverts back to its pre-closure equilibrium in a short number of years. For most of the outcomes, including employment and income, I find that the impacts actually tend to get larger over time. Right, and this kind of underscores the idea that, well, maybe there actually are shocks that are occurring within these rural communities that lead to this sort of sustained economic and population decline. When I think about heterogeneity, what I find is that these adverse effects are largest in counties that lose their only hospital, and in counties where the hospital makes up a larger share of the local labor market. This might not necessarily be surprising because in these two cases, you would think that the hospitals sort of are comparatively more important, say, than, if one hospital closes, but the county has another one that can sort of, employ people who used to work at that closing hospital, or also, care for patients that used to go to the other hospital. However, what I did find that was somewhat surprising is that these closures decrease non-hospital employment by almost 2%. And this represents about 40% of the total employment reduction. So this doesn't appear to be, the effects I'm finding, at least on the employment margin, don't appear to be just explained by employees at the former hospitals that closed. And then when thinking about welfare, the takeaway is that I find larger welfare reductions for older residents, but when I sort of aggregate and think about total welfare loss, what I find is the amounts quite a bit smaller than estimates of total operating costs for these hospitals. And of course, this has implications when thinking about, public policies that can maybe, help subsidize or keep these hospitals open. But I'll talk a little bit more about that at the end of my presentation. So this paper fits into two main literatures. The first is this broad literature that focuses on causes and consequences of local labor demand shocks. Of course, it's a very rich literature. My contribution here is that, again, I'm analyzing a unique industry, which I talked about earlier. It could affect both the demand and supply channels when a hospital closes. And also I'm focusing exclusively on rural areas, which I think is pretty understudied in economics, even in health economics. And so I think that this is an important contribution. The second, more directly related literature to this paper is, of course, focusing on hospital closures and their effects on the local economy. I'm certainly not the first person to think about this question, but when looking at the previous papers, what I find is that they're mainly case studies. They're focusing on, one or maybe two areas in the U.S., like Texas or in Appalachia, and so it's not entirely clear what the takeaway is from these previous studies. So here, I want to improve this stream of work by carrying out more rigorous quasi-experimental analysis using data from both closure and non-closure areas, thinking about heterogeneity and spillovers, and then of course trying to quantify welfare impacts and thinking about sort of a cost-benefit analysis between the welfare losses after hospital closures and the cost of keeping these hospitals open. So the data I'm using for hospitals and hospital closures comes from the American Hospital Association annual survey. I'm sure some of you are familiar with this data set. It's a very rich hospital level data set, contains a lot of information about ownership structure, employment, services that are offered. But also importantly for my purposes is that it contains a running list of all hospital closures as well as mergers in the United States. And so I'm going to take advantage of this data. I didn't just take closures at face value. The closures that were listed in the data, I hand checked to make sure that it wasn't a scenario where, say, a hospital closes, but then a year later it reopened either under a different name or a different owner. This was all done just using Google searches of the hospital, looking for media reports or government reports that confirm that the hospital did close. And then, so I collapse this data to the county level and merge in, a wide variety of economic outcomes, including wage earnings, employment establishments from the QCW. I used some data from the BLS, local area unemployment statistics, and then housing prices from a couple different places because at least public use data, housing or rental values for low populated areas like rural communities is not great, especially housing values. And so I try to supplement data from a couple different places like the Housing Urban Development as well as the ACS. And then finally, I use population data from the CDC and migration flows from the IRS. Okay, so the unit of analysis I'm thinking about is, or that I define, is the county. This is mainly done for tractability because the other data that I just talked about, a lot of it, the finest level you can get at is at the county level for these rural communities. And so I stick to defining it as the county level. However, another question comes in, well, how exactly do you define what a rural county is? And it turns out there's not really one way to do this. In fact, there's a pretty interesting literature that's devoted to just defining how do you define what rural is. And so there's a number of avenues I could take. I know the census has a definition, the Office of Management and Budget has a definition, but I'm actually going to be using a definition from Abui et al. 2018, where a county is classified as rural if it meets either one of these two classifications. So the first is that just the majority of the people within the county live in a rural area, and that rural area is defined by the census. The second is if the population density is under 64 people per square mile and the total population is less than 50,000. And this takes into account for larger counties, especially out west, like in Nevada, where the majority of the land is rural area, it's unpopulated, but within these bigger counties, there's sort of small smatterings of cities and towns where people live. So that's how I define what a rural county is. In terms of cleaning the sample, so I'm not going to be focusing on specialized hospitals. This is defined by the American Hospital Association. I'm only going to be focusing on general short-term acute hospitals, which is sort of, if you were to think about what a hospital is, that's what I'm going to be using in my analysis. I'm not going to be including prison hospitals or military hospitals, because when these close, it's always because the higher firm is closing, and I don't want to take those shocks into account in my analysis. And then finally, I'm going to be dropping counties that don't have any hospital in my sample period. And then in the handful of counties that had more than one closure, I'm only going to be looking at the first closure. Okay, so here's a map of the geographic variation in my data. I have almost 100 closures that I'm going to be looking at, and those are represented by the red counties. The blue counties are the non-closure control counties. The gold are the rural counties that I drop because they don't have a hospital in my sample. And then the white counties represent non-urban non-rural or urban counties. So this is just giving you a sense of what the variation looks like across the United States. Okay, so identification questions. I mentioned I'm going to be estimating a difference in differences model, and so causal interpretation of this requires that the outcomes would have evolved smoothly in the absence of closures. This is an observational study, and so there's certainly a number of threats to causal interpretation. The first is confounding trends. This I can test directly using event study analysis. I'll show you the figures in just a couple minutes. In any observational different diff, there's always a threat of some unobserved shock that's correlated with closures and economic outcomes as well. I do my best to guard against that by using different fixed effects interacted by time, as well as county trends and some specifications. And then there's, I guess, more nuanced threats like anticipation bias, where the idea here is that maybe in time t things are going okay in a county, but hospital owners anticipate that in a year or in 5 years the economy is not going to do very well, and so they decide to close in time t rather than stay open for a couple of years later. This one is a little bit harder to pick up in my estimates because of course I only observe when the hospital closes, the year that it closes. But what I will say is that I take all these threats to identification seriously, and my results are more or less consistent with the literature that finds reasons for closures. The main reasons for closures being low reimbursement rates for Medicare and Medicaid. For many hospitals, they cover less than 80–90% of the cost of care in these rural communities, operating inefficiency and poor management. And these presumably are uncorrelated with the outcomes that I'm thinking about. So here's my estimation strategy, pretty standard event study and differences designs. I'm using county fixed effects as well as state by year fixed effects to adjust the regressions. In some specifications, I'll include small number of time varying controls like a proportion of age, gender, race, and ethnic makeup of these counties. And then after I estimate the event study, I'll just collapse it to a pooled diff and diff using a binary indicator for whether a county experienced a closure. All right, so here's my first set of results. This shows effects on log employment and log per capita income. You can see in the pre-period, the pre-trends are relatively flat. And then the year that the hospital closes, you see a sharp drop in both outcomes. And also when you extend it over time, at least looking at the point estimates, they tend to get larger. And 5 years after a hospital closes, a closing county is experiencing about a 5% reduction in employment and about a 3% reduction in per capita income. The unemployment rate effects, I do find some small increase in the local unemployment rate. I wasn't sure if this was something I would find, as the literature is a little bit unclear about when you have population loss, would you expect to find would you also expect to find increases in the unemployment rate? I do find this particularly in the long run, about 0.002, 0.003 increasing the unemployment rate. The labor force participation effect mirrors the loss in employment. In effect, this explains about 90% of the total employment loss. The unemployment rate margin explains about 10% of that. And then for log establishments, again, I find, effects later on, about 3 years after a hospital closes. And then my last set of figures shows results for population, log rents, and then home values. I'm interpreting the home value estimate with a lot of salt, because as you'll see in the tables, the sample size is a lot smaller. There's just a lot of missing data using data from Zillow. The median rental data is a little bit closer to 100% coverage of all the counties. But of course, in rural communities, at least compared to urban areas, there's not as many people that are renting their homes. Most people, comparatively more people own their properties. And then for population, you see a reduction close to 1.5%, 2%. So here's a summary of the of my my baseline results. I guess the key takeaways are that you don't see a whole lot of change in the point estimates when you include time varying controls. Looks like the fixed effects are picking up a fair amount of the confounding variation. And again, when thinking about the unemployment rate, the employment rate effect, most of this is coming through the labor force participation margin. Okay, when you at least compare it at levels using the mean dependent variables, 90% of that is coming through the labor force participation margin. Only about 10% is explained by increases in unemployment. I also broke the population impacts apart by age groups. So younger people, people in the working age population, 20 to 64, and then for older residents, Medicare eligible residents who are likely out of the labor force. I find pretty consistent point estimates for these, a little over 1%. And then my effects for my results for housing prices, and you can see with the home values, it's I'm losing a lot of counties when I use that, and so I think I'm going to focus a little bit more on column 5. I think that's a more accurate measure of the home value impact. Okay, so I did a lot of different robustness, alternative specification exercises, the Bacon diff and diff decomposition, did propensity score reweighting to match, here I match closing counties to non-closing counties, different sets of weights, county border pairs. The results are more or less consistent across all of these specifications, and so, for the sake of time, I won't go into them. Although I did want to talk very briefly about effects for non-rural or urban counties. So I did the same set of analysis that I just presented. Here's the baseline results. I don't find really any effects. I mean, there's some significant effects on unemployment and home values, but then when I did a matching design to try to make my treatment and control sample a little bit more comparable, I don't find any effects. So this, appears to suggest that, at least from an economic standpoint, the effects from these hospital closures is more of a rural phenomenon than it is an urban phenomenon. And of course, there's reasons to think that, why that makes sense. There's more hospitals in urban areas. So, more people can get care locally if a hospital closes. And of course, people who work at these hospitals can, presumably it's easier for them to find employment within the same local labor market. All right, so quickly turning to heterogeneity. I do this 3 different ways. So I break the sample up by number of hospitals in a county after a closure, right? So if there's more than one, hospital that was still standing, or if the sole hospital closed. I also broke the effects up by the closing hospital share of county employment, whether it was above or below the median value, and then effects by ownership, if it was for profit or not for profit. So quickly, the takeaway with the first set of results is that counties that lose their only hospital explains the vast majority of the baseline effects I presented earlier. I still find some reductions in employment for counties that have more than one hospital, but most of these effects are all being explained by counties that lose their only hospital. Same for counties that have, where the employees, the employment at the closing hospital makes up a higher share of total employment within the county. So these aren't necessarily that surprising, right? You would think that these hospitals are just comparatively more important in the local labor market, and so when they close, you'd expect there's going to be a higher adverse impact across these outcomes. The last set of heterogeneity for profit, not for profit. So like a priori, there's not a big reason why I would expect there to be differences here. Presumably, for-profit closures are more, they could be more likely to close. They have less of a safety net. However, with most of these outcomes, like employment or labor force participation, the results are not statistically different. So I don't have a lot to say about this table. The takeaways is that the results are kind of noisy, and there's not a lot of differences between these two types of closures. All right, then the last set of results, reduced form results, think about spillovers. So essentially, what are the effects outside of employment at the hospitals that close? So I do this two ways. First, I net out, using data from the American Hospital Association, I net out employment from the counties that close, net out the hospital employment, and then estimate effects separately for two different sectors, the private goods producing and then service providing. So here's effects net of hospitals, and as I mentioned in the first set of slides, I find about a 2% reduction in non-hospital employment, and this represents about 40% of the total employment loss. The effects for income and total establishments, the magnitude of the point estimates are what I would also expect, but the standard errors are just a little bit too large to say anything about their statistical significance. And then breaking it apart by service providing versus good producing sector, all of this effect is really explained by service providing firms. This makes sense in rural areas. The vast majority of employment is in services. Although I guess I was somewhat surprised that I didn't find any sort of significant effects for goods producing, but nonetheless, it looks like all the non-hospital employment is really being explained. Unemployment is really being explained by losses in the service providing sector. All right, so to finish up, I want to talk a little bit about the welfare estimates. So using the reduced form estimates that I just talked about, I'm going to use those as inputs into a framework that was originally developed by Klein and Morietti, 2014. It's been extended in a couple of different ways. The key features of this model is that, I have many locations. You can think of these as, a rural county. They're populated by two groups, households and landowners. You can also add, firms to this model, but here I abstract away from that. The key difference between this model and, say, the Rose and Roback model that's very, very popular in urban economics is that residents have heterogeneous location preferences, right? Not everyone cares about where they live exactly the same as everyone else. So this is a more realistic assumption, but it also allows you to think about welfare effects for different types of groups. And so that's I would say my main contribution to this model is that I'm going to be breaking apart household types by workers and older residents. And again, the reason I do this is older residents use hospitals much more often than younger people, but they also have higher moving costs, higher mobility frictions. And so, when a hospital closes, you would think that the welfare impacts could be very different among these two groups. And so the assumptions I make in the model is that they have different incomes and they also have different mobility frictions. To give you an intuitive sense of what the model is doing, I'll just show you this figure. So the upward sloping solid red line represents utility from living in a county that's going to experience a hospital closure. The downward sloping blue line is utility from living in a control county. So when a hospital closes, equilibrium utility, which is on the y-axis, shifts down, right? This curve shifts down. That's going to decrease equilibrium utility. And the marginal preferences for living in the county also shift. So people who have preferences within epsilon star and epsilon star star move out, and residents that really like living in a county or they can't move, right? They have preferences that are in this area, they don't move. And so the total welfare loss, what I'm doing in this model is essentially estimating this this area here. And since I'm doing it for two groups of households, you could think that there's sort of two of these figures going on, right? One for workers and then one for older residents. And the shift is going to be, the magnitude of this shift is just going to be measured by changes in income and changes in amenities. So I'll try to skip the math here, but essentially what I'm doing, is estimating that area, one for workers, one for older residents. I model the change in utility as a function of earnings, local amenities, housing prices, and then local prices. And the big difference between utility for older residents versus workers is that I'm assuming older residents have a fixed income, say they're on Social Security, and so they're not going to experience a change in earnings. And they're also going to have different mobility frictions, different amenity values, which is why these two parameters are different. Yeah, I guess I'll just mention this last portion here. These equations just show you that I don't have estimates for amenities, but I can back it out using changes in income and changes in changes in population and changes in income. But the key parameter difference is that I'm assuming older residents have higher mobility frictions. That's what this S parameter is doing. And again, I'm abstracting away from the firm side of the model. I'm assuming perfectly competitive firms, and so they're not going to experience any welfare losses. And then I'm going to calibrate the model with my reduced form estimates I talked about, as well as using data parameter values that borrowing from the literature from a couple different papers. But the takeaway is that for both households, I find reductions in welfare, but the welfare loss is about twice as large for older residents. That's shown in point number 1. However, when thinking about total household loss, welfare loss, it's important to weight by the proportional share of residents in these two groups. And so when I weight it by the population share, the total household welfare loss is about 0.5%. For landowners, the welfare loss calculation is a little bit more straightforward. It's just the change in rental price plus the change in occupied units. The units I proxy with the change in population, and I find about a 2.5% welfare reduction. The total loss compared to income is about $1.5 to $2 million annually per county that loses a hospital. But when you compare that to estimates of operating costs of these hospitals, it's only about half, right? There's a number of estimates that I found. Think about how much it costs to keep these hospitals open, and $5 to $10 million is within the ballpark of those operating costs. So I just want to end my last slide here talking about policy implications and conclusions from this research. So there's been a couple of recent papers that found that there's there's ways that you can keep these hospitals open through federal and state policies, one being the ACA Medicaid expansion, others being more targeted programs to rural hospitals like the Medicare Critical Access Hospital Program. However, both of these programs are quite expensive, right? Of course, the Medicaid expansion did a lot of other things, but even the Critical Access Hospital Program costs tens of billions of dollars annually, tens of millions of dollars are spent per hospital that's in the program. And these are, numbers that are a lot bigger when compared to the estimated welfare reductions I just talked about. And so when thinking about, cost benefit, what policies are more efficient from an economic perspective, I would say my results suggest that maybe targeting hospitals that have that aren't necessarily at the highest risk of closing, but where the closures are going to have the largest economic effects may make the most sense from a cost benefit perspective. So thanks for listening. I hope you found it interesting, and I'm happy to answer questions and hear your discussion, Jason.
Thanks, Jacob. Could you stop sharing your slides, and feel free to both listen to my discussion and read a lot of the great comments that have been coming in as you were talking, because I think some of what I'll be showing is a restatement of the comments that occurred to people as you were talking.
Mm-hmm.
So just a really fascinating paper. I really enjoyed reading it. I grew up in one of these rural hospitals. It was like a regional hospital. I was born in a regional hospital that I think for the last 10 years has been concerned about closing. So I was really interested in this topic. But it's also quite true that I'm not an expert in this area, or really most of the adjoining areas that you're working in. So I'm rephrasing it. It's just maybe some of the rest of the folks on the call that find themselves in a similar situation. And you'll see that from the comments too. I think there was a lot of comments of clarification about how to think about this, because most of the people here are, health economists, health services researchers, and but probably have an idea of some of this adjacent literature, which is that I think of this as a plant closings plus kind of paper, which is there's a lot of papers on what happens to a local community when the one big employer shuts down. And the plus, though, is this issue that you raised, and you called them amenities, which I don't dispute, but I guess I would just add it's not maybe adding, maybe clarifying this fact that, the local provider, the hospital is both an amenity, but it's, all their customers are, in the area, which is not like the typical plant closings. I think of most of the customers of the plant aren't in the same county as the plant. And that's really, it's a hard thing to think through about what the implications are, and I think they come up in a couple different ways. So what I love the paper of having this focus on hospitals as like in the genre of plant closings, and just understanding what happens to places that lose a hospital. So I think both of those are great additions to the literature. Now, with great additions to the literature come, like, I think a lot of additional headaches from a research design point of view. And this issue that you're really looking at something new in a nationwide way is also, I think, the greatest challenge to the paper, which is that there's this tie to local populations. And this came up in the comments, I think, a few times, that I think when you describe a plant closing, and you might, and not you, when a researcher describes a plant closing paper and does maybe some hand waving about, well, the reason it closed is because demand for the product worldwide shifted down, and therefore it just had to close, or trade, or it could relocate to Mexico and get a lower, right? Those stories just absolutely don't apply here, right? And I think it means that you need different stories. And I think you provide some of them, but with very little evidence that those are the critical features of why some rural hospitals close and others don't. And this tie to local populations, I think, makes it just really hard. I think there's a high hurdle from the reader's point of view to think of many of these to be exogenous closings. And you'll see those from the comments in the chat, which is that, when I think of of the list of factors of why my hometown hospital will close. It's because the population is draining. There's just fewer people around, and that's first and foremost what I think the local population has in mind, is that it's just a hollowing out set of counties, and there's not enough births, and there's not enough services to survive. But it's not to say, I think there are certainly going to be cases where your list of bad managers and so on is going to be relevant. But I think really nailing that down, I guess a restatement of this is that I think this particular industry you don't have the some of the plant closings stories in your back pocket to say, like, this is why that we can believe it to be exogenous. So those are the additional headaches. I think you have a lot of the typical headaches too. And these also came up in the chat, which is that you're using difference and difference, and it has all the pluses and minuses that you outlined. And I think in this case, this came up a lot. Like I said, that it's just this question of where are the effects. So you have to make these choices. None of them are perfect. But count these hospitals affect counties, and they don't affect adjacent counties in the analysis. And there were some comments in the chat about maybe using commuting zones and so on. There's some pluses and minuses there, but the more general thing is that you have treatment effects with spillovers, and it's hard to figure out how to capture those as much as you can. So that's first. This is typical. Like, this would be true in a plant closings paper. It's not just your case. And then also was said in the chat, what precisely would we imagine are the untreated counties, right? If there's spillovers everywhere, how can we make sure you're not capturing part of these spillovers? Like, where are all these employees relocating to? Where so forth and so on. And in particular, I wonder how concerning. It's probably the answer is not too concerning, but I do wonder about using state by year fixed effects as a way of like forcing the spillovers to be included in the model in a little bit more direct way, because like the comparison groups are other counties in that same state and so on. So I don't think that's going to end up being really meaningful, but it's just like a for example of how to capture these spillovers. And you do, so I would push, as you move forward, push the decomposition of effects. What I mean by that is that when there's a hospital closing, presumably we know how many people are directly affected, and that might form our null in some sense of like how much we would expect over time there to be fewer employed and so on. So it's another way of saying like zero, is that really a reasonable null here in terms of like effects? So I think that's a small difference, but it's something I'd like maybe outline. And like you already raised, you examine other sectors, and maybe pursuing that more is the main thrust of that comment. And I think it's both interesting for this paper to have like a pooled, quote unquote, effect of a typical hospital closure, but I also encourage you to continue this line of research by, in some sense, going back to these maybe multi-case studies where you could really nail down, like maybe out of the 95 or 97 closures, you have 5 examples where it's just really clear that they closed for reasons that weren't related to the local population, and to trace those out and maybe to combine them. Because I think people would like both the really nice overall job you're doing here, but also some clarity of, in these cases where we know it's not, where we really nail down causality, we really, and that also these case studies might allow the second point of tracing these spatial features around, because you can really focus on figuring this out on a case-by-case basis. So again, I really like the paper. I really like this direction. I think it's a hole in the literature that has a lot of upside to pursuing. So those are my main comments, and then I'll stop here and ask you to either decide to respond to anything in particular here or in the chat.
Okay, thanks, Jason. Yeah, I guess because especially with like the spillover question, I think that was mentioned by you, and it was also mentioned by a number of people in the chat. So I was thinking about spillovers in a couple different ways. First was wanting to estimate directly what they are, I provide some within county spillover estimates, the non-hospital employment effects. But of course, I was curious about, what are the effects on adjacent counties? But at the same time, thinking about that can also be somewhat of a confounder if there are spillovers. So I mean, one idea I had was like, I think maybe this was also brought up in the comments, is for at least for a sensitivity check, is just like dropping adjacent counties. This doesn't completely solve the problem, but if there are people who are moving, maybe to a neighboring county, they're more, I guess you might think they're more likely to move closer rather than farther away. I don't know if that's true, but that's something that I could easily do, is just, keep my sample but drop adjacent counties to the ones that close. And I also agree with your last comment. In some ways, this is like a proof of concept type argument, right? Closures that, you can really provide evidence that they're very exogenous. I don't have a great way. I mean, I can look at media reports. I can think about why they're closing. But yeah, maybe I can focus on one or two of those and just add them maybe as like a first set of analysis and say like, okay, I find these effects and, see how they compare to the pooled effects that I estimate using all the closure counties.